Hello, good evening, sir.
Himanshi, you can stop recording, start recording when we start. Otherwise, जब आप अपलोड करते हो ना उसमें ये प्रिलिमिनरी टॉक्स भी आ जाती हैं. You can stop.
Yes, sir. Good evening.
Good evening. Good evening.
Good evening.
Good
When
evening,
we
sir.
start
Good evening.
formally, then you can start recording.
Good evening, sir.
Hi, Biju.
Hi, Biju.
Good evening, sir.
पूरा फाइल बना के नहीं भेजा तुमने फाइल अंदर का
आज क्या बॉल फेंकोगे?
हाइट वेट करवा दूंगा पूरा हाइट वेट करवा दूंगा ओके ताकि मेरे
Good
रिकॉर्ड
evening. Good evening, Dr. Prateek Ghimre from Nepal. Good evening.
मैंने वो ये कर लिया अच्छा आप और बताओ जी मैं छोड़
टीडी जी नमस्कार.
सर नमस्कार सर. जस्ट ज्वाइन कर. यस
हाँ,
सर.
हाँ. Yes, yes.
बट डिफरेंस इन द टेम्परेचर.
हाँ.
देखो बैंगलोर में रहो, आराम ही आराम है.
सर सबके तकदीर में सब कुछ थोड़ी होता है. आपके मजे हैं. आप लखनऊ, बैंगलोर, पूना, पता न कहाँ कहाँ. ओ यहाँ पे तो 2 डिग्री तक चला गया है. सारे रिकॉर्ड टूट गए हैं चंडीगढ़ के.
रियली?
यस सर.
नहीं, जयपुर भी बहुत ठंडा है और अभी मैं लखनऊ गया था एक दिन के लिए, वहां तो और ज्यादा ठंडा था.
नहीं, ये चंडीगढ़ का तो अभी सर 0 तक आ गया था. आज तो थोड़ा सा कल से लगता है बेहतर है. आई डोंट नो जरा सा.
हाय विजय. हाय.
अजय, तुम्हारा वीडियो नहीं ऑन है.
मुझे 3 मिनट लगते हैं साथी सेटल करने में.
Hello.
गुड इवनिंग अनु.
तो बोलो सर मैं
Good evening, sir. Good evening, Dr. Sadhu.
गुड इवनिंग. गुड
हाय.
इवनिंग.
हाय अनु.
Very nice to see
कहाँ
all
गया?
of you.
सब ठीक है?
हाँ जी.
PGI is all good.
हेलो अविनाश.
गुड इवनिंग सर.
All good, sir.
सादिक सर गुड इवनिंग.
नमस्कार. नमस्कार.
नमस्कार.
सर
हाथ जोड़ के नमस्कार कर दो.
जी सर. कपूर सर इससे रिक्वेस्ट क्या है कि हमें यूट्यूब पे टाइमली जाने के लिए 2-3 मिनट पहले स्टार्ट करते हैं ताकि प्रोग्राम टाइमली स्टार्ट हो जाए सर. ये
हाँ, वो ठीक है, लेकिन मैं ये कह रहा था इनको, हिमांशी और कृपा को, कि
जी सर.
रिकॉर्डिंग जब हम फॉर्मल सेशन शुरू करें तभी ऑन करें.
तो सर 2 चीज होगी. अभी यूट्यूब पे अभी तो लाइव हो जाएगा लास्ट के 2-3 मिनट पहले वाला, क्योंकि सेट करने में वो 2-3 मिनट टाइम लगता है, फिर आगे लेट हो जाएंगे अपन. लेकिन जब अपने इंडिविजुअल वीडियो जो होंगे जो बाद में लोड करेंगे उसमें सारा डिस्कशन डिलीट कर देते हैं सर. ये
कर दोगे? ठीक है.
ओके. थैंक यू सर.
तो फ्यूचर से हम पार्टिसिपेंट्स को इंस्ट्रक्ट भी कर देंगे जब आप बता दोगे कि
हाँ.
आफ्टर दैट पॉइंट वी डोंट डू एनी इनफॉर्मल काइंड ऑफ टॉक.
यस सर. यस सर. तो अब सर अभी रुक जाओ, अब मत करना.
ओके.
जी सर.
तो पहला टॉक डॉक्टर बीजू का है. बीजू इज देयर, अजय इज देयर. आई थिंक राजेश भोजवानी विल जॉइन इन द मीन टाइम, तो मे बी वी विल स्टार्ट ऑन टाइम. तो इट इज 7. कैन वी स्टार्ट, हिमांशी? कृपा?
Yes.
Okay. Good evening, everyone. Welcome to the 7th Jaipur Surgical Tutorial Masterclass. For those who are going to attend and watch this program for the first time, just a brief introduction about Jaipur Surgical Tutorial. This is an online educational portal which we started about 2.5 years ago after I moved from SGPGI Lucknow to Mahatma Gandhi Hospital in Jaipur. And all the educational activities of JST are being coordinated by my colleague, Dr. Anand Nagar, who is an associate professor of HPB surgery and liver transplant at my new institution. And the technical support is provided by the team of Dr. Avinash Tank at Dwarika Clinic in Ahmedabad. So we conduct a session every Saturday morning, 9 to 10 a.m., where students present cases or operative surgery sessions, and they are moderated by faculty. So that is going on. In between the sessions, I'll project a slide which will show you how to join Jaipur Surgical Tutorial if you are not already a member. But in addition, we thought that we will conduct these single theme master classes. So the videos of all the previous 6 master classes, which have been recorded and edited and prepared by Avinash's team of Himanshi and Kripa, they are available. I will post those links also for those who are going to attend for the first time. So this masterclass today and tomorrow, the topic is post-cholecystectomy bile duct injury. And we have almost everyone from the country who has been involved and who has contributed to the management of post-cholecystectomy bile duct injuries. Most of the panelists are from SGPGI, where fortunately or unfortunately we had collected world's largest single institution experiences with the management of both acute bile duct injury and post-cholecystectomy benign biliary stricture. So in this masterclass, we are going to discuss only the immediate or the acute bile duct injury, not established biliary stricture. And to moderate this session today, I have requested 2 of my former colleagues from SGPGI, Dr. Sikora, who has made invaluable contribution to the theme of safe cholecystectomy and management of bile duct injury, and who's currently at Sakra Hospital in Bangalore. He's the president of the Indian Association of Surgical Gastroenterology. And Dr. T.D. Yadav, who's currently at PGI Chandigarh. He is the secretary of the Indian chapter of the IHPBA, and again, his contribution has been in biliary surgery, both bile duct injury and gallbladder cancer. So with those words of introduction, I hand over to Dr. Sikora and Dr. Yadav to moderate this session. Sadiq.
Good evening. Thank you, Dr. Kapoor, for once again inviting us on this masterclass. And good evening, TD. So today, together, we'll try to sort of swim through this session, and hopefully we'll have a lot of interactive questions in this. So the first one is our former colleague, Dr. Biju Pottakkat, who's now a professor at Jaipur, Pondicherry, professor GI surgery and head of department. So he's going to speak on when you see bile during cholecystectomy, what to do and what not to do. So Biju, without taking much time, let's start with this.
Thank you, sir. My slide is visible?
Yes.
Yes.
Good evening and thank you to all. And it's my privilege to have the opportunity to express my thought in front of such a high-end and highly experienced senior colleagues who have immensely contributed to this bile duct injury and issue of safe cholecystectomy. So I'll just share my some thoughts in the next 15 minutes. So when you do a cholecystectomy, when you see a bile or a suspected situation, first we recognize what is abnormal and what is normal. So when you see a bile, what is probably normal is if you have a bile leak from a positively identified cystic duct or from a positively identified liver bed small ducts, it may be normal. Still, I'm telling you, it may be normal. But what is definitely abnormal is a golden bile in the field appeared anytime. Even if it appears and then disappears, it is abnormal. And clips or sutures placed in the common bile duct area. And in an attempt, when we do cholecystectomy, sometimes we see bile leak and you place clips and it disappears. That is also abnormal. Why this approach is required? Because in bile duct injury, generally we follow a sensitivity approach. We do not want to miss anything. Even if it turns out to be no injury later, missing a bile duct injury is not acceptable. And literature also says that bile duct injuries, a good number are not recognized or ignored. Now, when you see a bile leak, what exactly is a bile duct injury? So again, when we do a sensitivity approach, not to miss approach, any bile stain during or after cholecystectomy should be considered as a bile duct injury. This is one of the most important message we have to communicate all over. One of the issues we are facing in the definition of bile duct injury is missing the diagnosis and detection of bile duct injuries with the classification systems. This should not be done. There are injuries which are not within the ambit of the classification. That's why there are 20 plus classifications, and any bile detected during cholecystectomy should be considered as a bile duct injury, which can be proved otherwise later. So for the purpose of this discussion, I normally approach the bile duct injury as open inside, open outside, and closed. Closed is stricture or clipped. Open outside is with a drain. Open inside is bile leaking into the peritoneum. Now, when you see a bile, one of the foremost thing what we have to think is, did this patient have any predisposing factors for this injury? Was this patient at a high risk of injury? Because these predisposing factors significantly contribute to the injury. Whether there was acute cholecystitis, whether the GB was contracted, especially in northern part of India, whether the field was frozen and you try to demonstrate the anatomy, the Mersey syndrome was there, cirrhosis and portal hypertension. So in these patients, when you see a bile leak, this bile leak has more importance than seeing a bile leak in a very simple or straightforward cholecystectomy, because here the chance of injury is more, and even if you see a drop of golden bile, that is usually a problematic area. That will usually end up in a bile duct injury later. Now, what we commonly advocate is a safe dissection, critical view of safety, and all the benchmarks of anatomical landmarks of the dissection. But sometimes what we also have to see in the operative field, when you see a bile, is did we do excess anatomical dissection? So in the left-hand field, you can see that we thought it is a cystic duct, but a cystic artery, but ultimately it turned out to be the right hepatic artery. So if we did already an excess dissection and seeing a bile on table, what we have to assume is there is a very high chance of bile duct injury in this patient, just because of the fact that we have done an excess, unnecessary, proper anatomical dissection delineating the arteries and ducts. So this has to be avoided. And if you see this sort of picture on table and a bile, you can you have a very high suspicion of bile duct injury. So when you see a bile, what are the points which should go through your mind? One is, will you call a colleague? This part Dr. Ajay will discuss later. Will you talk to the relative about the bile duct? Before doing anything, stop and think all this. That's what my advice. And will you, and if yes, how will you assess the extent of bile duct injury? If you see a bile on table, how will you rule out other injuries with a reasonable certainty? Will you, and if yes, when will you perform a primary repair? Are you okay to do it? And what else you will do if you don't do a primary repair? So the moment you see bile on your screen in laparoscopy or intra, these are the points you have to think, take a break for 5 minutes, think it, be ready with answers for all this. That is what the one of the first thought process of philosophical thought you have to keep in mind when you see a bile on table. Now, another common problem we try to rectify always in any session related to bile duct injury is the word bile duct is actually underestimate the extent of the problem. Okay. So it is not this injury is something beyond the CVD problem. It's not just some rent in the CVD, because this injury can throttle the liver. We are actually injured the excretory outlet of the liver. There is a permanent traffic jam there, or traffic jam can be formed. And this patient, this bile is leaking into the peritoneum instead of intestine. So it is not just like a common bile duct stone or other CVD problem. It's actually rather than CBD, it is now we landed up in a problem of the liver. So this is one of the important differentiation. We have to make our mind that when you have a bile on table, now that surgical part you are converted into a liver problem rather than a common bile duct problem. Now stop and think about the patient. So this patient came to you for a simple gallbladder problem. You told him 50,000 to 70,000. And now what happened on table, if you say bile duct injury, majority of the situation, this has been converted to another complex HPP problem. Immediately, within a few seconds, a small problem blown up out of proportion to a mountain issue of mountains. And the immediate issue what we have to face is you have always be sure that that patient lost trust on you. That is one of the first important point we have to keep in mind, irrespective of your experience. Normally, we do not explain too much about the bile duct. So loss of trust of surgeon is an important issue. Now, what are the possible risks of bile leak you have to think when you see a bile? Recorded. This can cause death. So a gallstone disease will not cause death normally, but bile duct injury can cause death. There can be reoperation, reintervention, and patients who survive, even if you repair, there will be prolonged morbidity, jaundice, cholangitis, chronic liver disease. And the cost of management of all this, probably this is one of the earlier studies from India. So it is around 10 times than cholecystectomy. So the problem starts in terms of health, morbidity, quality of life, cost, and multiple occasions we have seen that patients who were forced to sell their house and land just to get rid of the issue of management of bile duct injury. So with all this in mind, your mindset should be first accept the injury, realize that you injured the drainage to the liver, think of the patient, and next, in the next session, probably we are going to discuss the moral right to repair a self-created injury. Now, another misperception, the moment we start seeing a bile, the common perception, we try to underestimate the problem and think about all the available classifications, the literature will take out and try to teach our residents or juniors or sisters that this is this type, that type, and all that. Okay. This is a very bad practice because neither this is the time to think about classification, nor your classification might be correct, may not be correct in future. Okay. So the problem here is think of saving the patient and think of saving the bile duct as well. So this is not the right time to think about the classifications. Why this is not the time, right time? Because this is one of our evidence when we had a large experience in Lucknow. Ultimately, what happens, 39% of the bile leaks or injuries remains unclassified. This remains unclassified and it closes off, it seals off, or beyond classification. So this is exemplifying the fact that when you see a bile, that the least thing you should do is try to classify it. Self-management, put it as a last option. Are you an experienced SPB surgeon? Do you have all these facilities? And especially surgeons think of these gadgets and all. If you don't have, it's better not to repair at that time. Always better ask a colleague to have a look, even if he's your enemy. Call a surgeon first and not an endoscopist. Okay. One of the important thing, probably we make it wrong, is we always think about an endoscopist who's going to put a stent in the bile duct. This is a surgical complication. Here, the first opinion has to be from a surgeon. Call a surgeon, then make a decision, record the injury, and the record the second opinion, also record that who came to operation theatre. In this era of litigation, it's always important to record the second opinion. This will really save you in courts and other further consumer forums and all that. Now, what to do with the gallbladder? So you may be in a situation where gallbladder is intact, partially dissected, and bile leaking. if you're not planning to repair yourself, leave the gallbladder as such and do not attempt to complete the cholecystectomy, because this can further damage, further devascularize the area. So leave the gallbladder intact. One important reason is this will help the next surgeon to manage the patient in a better way. Now, another common wrong approach is we try to dissect and delineate the injury further by retracting, by dissecting, and by hooking, by suturing and all that. This should not be done if you don't have a sufficient expertise. The reason is, now once the injury happens, it can be because of the cautery, it can be because of the scissors, it can be because of the any other instrument, but there is a significant possibility of devascularization of the injury. So the pericholecystic plexus as well as the other left and hepatic artery and supracholecystic plexus very important in the further repair and management. These are the arteries which actually feeds the stricture in future. So never try to dissect further in and around the bile duct. So why you should not dissect? Because most of the retrospective evidence showed that one of the very important reasons for bile duct injury, bile leak, is the wrong perception. So if you have a wrong perception during cholecystectomy, there is no reason why your perception should be correct during further dissection or repair. So a wrong perception already happened during cholecystectomy. That perception may likely to happen in the further repair also. So don't dissect too much. Now, just don't go and convert just like that. Why it should not be done? Because just to diagnose injury, you should not convert. As I already told, you have seen an abnormal bile. It is a bile duct injury unless proved otherwise. If further plan is not clear, don't convert. And even if you're planning a repair, be sure that you should have sufficient expertise and gadgets to do a small duct repair. Otherwise, just drain the subhepatic and come out. So tubing the hole, sometimes you might be seeing the hole in the field below or above or blind holes. So aim has to be very clear when you tube it. Cholangiogram, it is fine. But normally these tubes will slip out later and it won't help much in making it an external biliary fistula. So the usual thought process after you see a leak is just name it as, okay, it can be from the duct of Luschka. The duct of Luschka is very commonly mentioned beyond its possible anatomical existence. Let us say it is 3%, at least 20 times we might mention a duct of Luschka during cholecystectomy. And don't try to put gauze, sponges and mop at the leaking site. And even if you put a drain and later, don't think that it is going to subside just like that. And don't try to simply blindly. These are the 4 things you should not do when you see a bile leak. So initial simple thought process will be close weight, open inside, make it open outside and wait. So here is a situation where it is open inside. And the minimum you should do is make it open outside. Now we have time and experts can make it right. It is not mandated that you should make it right. We have experts to make it right. And the initial part should be avoid mortality and control sepsis. So the key for all bile leak on table, whether you identified it, not identified, is draining the subhepatis. It's not exactly draining the injury or near the injury. It is the draining subhepatic. Important thing, that is the lowermost point in supine position, the abdomen, and that is where it is going to collect. Most of the sometimes what we see is you put the drain in abnormal positions. There will be biloma there in the epigastrium and other areas. Drain is there, but not in subhepatic. This should not happen. So please remember that our aim is not to drain the collection. Our aim is to drain the collection as well as drain the making it as external fistula. So the critical drain is subhepatic drain. Other collections are going to resolve. So intraoperative ERCP, if you are very sure, surgeon, endoscopist, both are clearly experienced, you can try to stent it, but in a very minimal proportion of bile duct injury, bile duct type, injury types only, it will help. Now, the intracholangium may help to detect a bile leak. It may identify the site. It may identify the anomalies as well. So, if you have a facility for intracholangium, use a small DJ tube or small stent, cannulate and do a cholangiogram and see it. But this is also important only if you are planning to repair. Just diagnose and your ultimate plan is referral. This also is not going to help. Two problems we have to remember is injuries are more in degree than anticipated or seen on table, and this injuries gets upgraded with time. So at that time also there are three situations. You identify injury, let's say 1 millimeter injury, it can be 3 millimeter at that time, it can be 10 millimeter after 6 months. So early repair, you have to carry a lot of conditions have to satisfy when you are looking for early repair. Otherwise, the safest approach is think and plan for a delayed repair. Now, when you decide on the repair, you should have all this in hand: retractor, gadgets, adequate assistant, cholangiogram, small loop, and post-operative unit. So another important thing we forget is we think that we can repair it, we repaired, and then don't refer. Okay. Refer for repair than the repair refer. If you are any time thinking that, okay, you can refer after repair, that is a bad idea. Refer for repair rather than repair and refer. And there is a difference in if you now you opted for a primary repair or biliary anastomosis, there is some difference you have to keep in terms of biliary stricture repair and acute bile duct injury. Biliary stricture repair, we do not do end-to-end repair. It's a functional end-to-end, but technically it is a side-to-side anastomosis like this. Okay. But in this acute bile duct injury, normally you will end up in a end-to-side anastomosis because these bile ducts will be very small. One of the important points you have to remember when you do a primary repair is the pericortical tissue, as I mentioned, is very critical for the blood supply. So if you end up in doing a primary repair, your dissection should be right outside the portal vein or hepatic artery. The bile duct should carry a thick pericortical tissue along with that to ensure that the plexus are intact and you do not end up in very thin bile duct. And direct end-to-end repair is also feasible, provided that you should have sufficient expertise. If it restrictures, your endoscopy should be able to stent and dilate like a low type 1 or type 2 bile duct stricture. But at the same time, ensure that you have adequate loop and other gadgets for this. And ultimately, in summary, we are looking for key answers when you have a bile leak on table, when to self-manage, when to defer doing anything, and when to refer. These are the three key points I want to emphasize, that at the end of seeing a bile leak, if you decide at least opt one of these three, preferably the third one, that will be a good idea to manage bile duct injuries. Thank you very much for the kind attention.
Thank you very much, Biju. So let me invite Dr. Yadav for your comments, and we'd like to hear from you about this topic.
Thank you, sir. Most of the important point Dr. Biju has covered. So I personally feel we can be a little bit more precise that if you are doing laparoscopic cholecystectomy and you find that bile is in the field, so then you have to decide whether you are competent and trained and your system is also having all the facilities what Dr. Biju has said to manage a bile duct injury, or you are working in a center. Even if you have some experience, are you having all the gadgets where you can manage a bile duct injury once you have go and try to identify and try to see the grade of the injury. So if you are doing laparoscopic cholecystectomy and you are working in a best center, everybody can have a bile duct injury. So then probably one has to think about doing intraoperative cholangiogram laparoscopically and trying to look into the system, whether it is as Dr. Biju says, sectoral injury, or it is injury to the main duct. If it is a sectoral injury, is it communicating with the main system? If it is, then probably you can put a clip or like take a suture. If it is not communicating to the main system, which is type Strasbourg type BRC, then you have to see what is the size. And if it is very small, you can still get away with the clipping or putting some sutures. If it is not, then probably then you have to think that I am going to convert and do some sort of biliary or cholangioenteric anastomosis. But if you are working, as Dr. Biju is emphasizing, working in a center where all these facilities of magnification and retractor and expert surgeon, HPV surgeon is not available, then probably if you have not taken the gallbladder, don't do anything, just put a drain and refer. Even if you have tried to taken the gallbladder out, so if you are suspecting bile duct injury, no need to dissect more, because damage would be more if you are dissecting more. And just to convert to just document that I have done a bile duct injury is also not justified. One important point, Dr. Biju, I think you emphasized, but like as you say, then once you have put a clip and you are proceeding further dissection and you are finding another duct, what you call is second cystic duct or sectoral duct. So one has to keep in the mind that the first one was the common bile duct, and the second one is probably the main cystic duct. So these are the certain finer points by which you can be more, your suspicion should be more when you are having these ideas in the mind, that suddenly after doing some dissection, you are finding this type of this thing. Third important point is when you are cutting the, you have support, you have ligated and cut it. And if it is falling back, dipping towards the duodenum, it means common bile duct has been cut. But if you are after cutting and you are seeing that your cystic duct is going and going down, it is parallel to the direction of the common bile duct, probably 90 degree or something like that. It means that you have done the not done the bile duct injury. These are for the difficult cholecystectomy, where, as Dr. Biju said, in group certain percent of the patient you are not able to. You won't be able to really have a critical view of safety. Then one more important point, that if you are not able to create a critical view of safety, then if it is funnel-like opening of the cystic duct in the gallbladder, and you can probably dissect more carefully without doing any energy source and going to the Hartmann's pouch and trying it, this cystic duct going and being a funnel, widening toward the gallbladder, then probably leaving little bit cystic duct and clipping there might save bile duct injury. And regarding management, most of the points have been highlighted, and one has to really, if one wants to really repair, then all those points which has been said by Dr. Biju should be taken into account. Most important is, if you are using this harmonic scalpel and all those instruments, then even bigger vessels can be coagulated, and you probably miss the right hepatic artery or something. So if you are trying to repair on the on table, then even the reports are that even HPV surgeons, their outcome with the intraoperative hepaticojejunostomy vis-a-vis delayed repair outcome is poorer in a intraoperative this thing. So these are important finer points. I thought, okay. Thank you, sir.
Thank you. Thank you very much. Thank you for your inputs and all. So let me just, in a way, summarize the important points which you have made, Dr. Biju. I think you made the point that the type of disease is very important because it is high risk for injury. So when you see bile, I think we got everything together in this, although the topic has been broken into who to repair and how to repair and all that. But if we concentrate only on bile seen during cholecystectomy, as you mentioned, the abnormal and normal bile, you have to distinguish. I think central or peripheral leak is important. If it is coming from the hilum or from the hepatoduodenal ligament and it's golden bile, you are worried. If it is identifiable leak, you can sometimes, you have nicked the gallbladder, most of the time do 40% of time there is a hole in the gallbladder and there is bile leak. And if it is identifiable, it's good. You don't need to panic and do whatever, continue to do what you have to do. But a difficult gallbladder, central bile leak, which is golden bile, and it is during the time of dissection in the area of hepatocystic triangle. Those are the times when you should be worried, as you highlighted. So the second important point, which you said it, what not to do. So do not remove gallbladder if there is high suspicion. Do not dissect CBD if there is high suspicion. Do not convert only for the sake of identifying the injury, and do not tube. I think these are very important points which we need to remember what not to do. One of the things is when to identify that it is a major bile duct injury and not some peripheral injury. So site of injury and timing of when the bile is seen at the time of injury is important. But if it is unclear, I think that is the point you may want to do a cholangiogram. Of course, you need to have facility, and we have to make sure that in trying to do a cholangiogram, you do not worsen the type of injury. So if you have all facilities, then you do a cholangiogram, define the injury, and then take steps accordingly. But if you don't have facility, and if it is a high degree of suspicion, then you follow the algorithm as Dr. Biju has highlighted. I think the last 2 points which you said, defer and refer, are also critical words and terminologies which we should keep in mind for all concerned, whether experienced, inexperienced, in a peripheral place or in a tertiary care center, because at every stage, based on what kind of injury it is, you may choose to defer and you may call somebody else to do it, which we'll discuss in the next talk. So let's see if there are any questions. Yes, Dr. Kapoor.
So just a few points. So of course, they will all be repetitions, but I think they are important. So I would repeat it. And my comments are basically for our target audience, which I presume is general, minimally invasive, laparoscopic, non-biliary surgeons. So these comments are not for anyone in the audience who is a biliary surgeon. And my definition of a biliary surgeon is any of us who does a biliary enteric anastomosis as a routine, frequently and regularly, not once in a blue moon. He or she is a biliary surgeon. So my comments are not for a biliary surgeon, but for a non-biliary general surgeon. First is the magnitude, as Biju said, that a plain, simple, short stay, easy, good recovery operation gets converted into a major complication that every one of us has to understand. And we have to be careful on that. That, of course, is a separate topic, how to prevent it. Second is that any bile leak is a bile duct injury unless proved otherwise. So intraoperatively, if bile is seen, it should be considered as a bile duct injury. How do you prove it? I think the word he used, that take a break. And I always say bile during cholecystectomy is like the yellow signal on the traffic light, which means that you have to stop, look here, look there, and then only proceed. So how do you differentiate between CBD bile and gallbladder bile? CBD bile, as Dr. Sadiq said, will come during the central dissection, in the Calot's triangle dissection. It is thin, watery, golden yellow in color, which flows freely on the tissues. Whereas gallbladder bile is thick, viscid, greenish yellow in color. Sadiq, the questions on chat will come, from the audience will come on chat. Hemanshi, would you send the questions to Dr. Sadiq? Yeah, you've already sent it to me. Maybe send it to Dr. Sadiq directly so that he can take them up. So that is important. If possible, take another opinion so that you get a fresh, unbiased opinion. The person who comes in the theater at that time is not suffering from the visual perception error, which you may be suffering from. Very important is this: do nothing. If you are not competent to handle a bile duct which is undilated, normal sized, a few millimeter in diameter, do nothing, which means no cholecystectomy, no cholangiogram, no T-tube, no repair, and no hiding this complication from the records and from the relatives, because that is one of the reasons for a medico-legal problem later on. The role of endoscopist comes in the post-operative period, where you have a bile coming out and you want to delineate either the anatomy, for which MRCP is better, or you want to drain the bile duct in order to control or decrease the fistula output. So these are some points which I thought need repetition. Sadiq, I have got the questions here, so I'll read them.
Please.
Dr. Tetraj from Mauritius, he's been a visitor to India some time ago. He says, in case of a lateral CBD or CHD injury, is T-tube placement via the injured side and suturing the rent, or cholecystectomy? So whether to put the T-tube through the rent or through another side, and how do you close PDS 40 interrupted? What is your opinion about it?
So when you say a bile duct has to be identified. So first point is bile duct should not be dissected during cholecystectomy. That is the first important point. Now, to identify that that is the bile duct, you need a cholangiogram. That is the point number 2. So if you positively identified that is the cholangiogram, and you have the expertise, laparoscopy expertise to suture it in a reasonably good diameter duct, you attempt it, but at the risk of stricture. Again, the stricture. Now, one important point here is, these are the injuries. You think that it's a type A injury, but these injuries can be stented endoscopically also with equal success. So, endoscopy is a transpapillary without further damaging that area. So, think whether that is the best option, or again meddling with that area, dissecting it and suturing is another option. To suture it, some dissection around the bile duct has to be there. And probably if you don't have much expertise, I advise not to do anything. Cholangiogram and think of possible YASI.
So if any of the panelists would like to make some other comment, we have about 2 minutes before we move on to the next topic.
I would like to ask Dr. Sadiq. Sir, suppose if surgeon sees bile during lab chole while doing lab chole in his OT, and if the surgeon wants to decide the patient to be referred to you, so what are the pointers which would you like to have then in the referral note? What kind of referral note he should say? What all points he should include while referring it the patient?
So let's.
Before Sadiq answers, let me introduce Dr. Abhinav Sharma. Is a leading gastroenterologist in Jaipur. He is again an SGPGI alumnus. Yeah, Sadiq.
So, I mean, I'll ask Biju also to say, but see, I think that's a very important point. We need a complete operation notes, wherein that at what time and how much dissection was done and what was the condition of the tissues at the time when they saw the bile and the stage of dissection. I would say that if there is a recording available, I would like to get the recording. And actually, you would be surprised at the number of times which they are able to provide that. So, often we feel that nobody records and all. Yes, perhaps 50%, 60% don't. But if 30, 40% do record, I would like to have that recording, because that gives you a full information of that. The third thing which I would want to know, if the recording is not there, was there any bleeding which was significant enough for them to do something? Sometimes they forget to mention that. And in that situation, you don't keep in mind whether there was associated vascular injury or not. So the operative findings in detail, whether there was any significant bleeding which required control, and the nature of the disease which they encountered. If it is an acute thing, at what stage they did the cholecystectomy. And finally, as I said, the most important thing, if it is available, is a video recording, because it has made a big difference many times that I have faced this situation. Biju, TD, you want to add something?
Biju, you are muted.
No, nothing to add, sir. That's...
Biju, one last question from Dr. Vishal. He sent it to me directly. Vishal Gupta, he's the chief of GI surgery at AIIMS Bhopal. He's also contributed a lot to safe cholecystectomy concept and philosophy. He says if the cystic artery has already been clipped or divided, then can we leave the gallbladder in situ? Is there a risk of necrosis?
No, there is no risk of necrosis if it is not detached from the liver bed. It will survive. So, because the acute course and other issues won't happen because you already divide the cystic duct. Now only collected bile or some leaking bile will be there. It will get perfused, no risk of perforation. So it can just be left alone.
And moreover, we are doing this in a situation where you are referring. So something you expect the referring doctor to be doing, minimally a laparoscopy, and at that time, assessment and removal of gallbladder. So I
No,
don't
but
think that's
not necessary that after referral, the patient will be operated.
No,
isn't
but
it?
if the patient goes and is referred and the gallbladder is in, I think it is imperative that at least the person A will assess the injury, and B, we need to get the gallbladder out. We can't leave it interminably.
Okay, I think we can move on to the next. Yeah, Abhinav, you want to say something?
No, sir. My question
Okay.
is answered.
Okay.
Thank you.
Sadiq, please move on.
Yeah, TD, you want to take over the next talk, please?
So I think this Dr. Ajay is going to take the next talk about the repair of bile duct injury, and we will take up the question and give our comments later. Dr. Ajay, please go ahead.
Hey, good evening, TD boss. Good evening, Dr. Kapoor sir, and good evening, Dr. Sadiq sir. And it's really a nice opportunity on a topic which I think is less of a scientific topic, more of a social and other socio-economic factors into it. I'm sorry that I did not have much time. I was attending some other course for last few days, and I saw the topic at the last moment. So I'm sorry because I could not make it as well as I expected. So I'll just share my slides.
In the meantime, Biju, if you are still there is a question from Dr. Nabeen Padial in the chat. Maybe you
Yes,
can address
Is my
that.
slide scenes just can I?
Yes,
So,
yes.
Yeah.
So
Okay.
Yeah.
slides are
Ajay, just wait for a minute.
Yes.
There is a question from Nepal, which I will request
Yes,
Biju to
please.
take.
So, is it regarding the how to select cases for cholecystectomy for the beginners? Probably biliary colic patients with biliary colic, ultrasound, no contraction of gallbladder, distended gallbladder, no other predisposing factors, and most importantly, put the scope in the presence of a senior and see, then proceed. That is the best thing. Put the scope and then decide whom to operate. That's what even now with I think most of the teaching centers do. Despite assessing the simplicity of the surgery or difficulty beforehand, we decide who will do only after putting the scope and see the situation. That's a very important point.
Yeah, I will just add to it that avoid all the risk factors or predictors of a difficult gallbladder, and that so which means young patient, female patient, thin-built patient, only biliary colic, no acute cholecystitis, no long history, no acute pancreatitis, no CBD stone, normal LFT, distended gallbladder on ultrasound, thin-walled gallbladder. If you avoid all the other risk factors which predict a difficult gallbladder, most probably you will have a simple or virgin gallbladder. And as Dr. Biju said, if you have the facility that you can call for help after putting the scope, then obviously that is the best time. Ajay.
Okay.
Yeah.
Thank you, sir. As always, in almost all the conferences, it happens, the speaker before you steals away half of your topic. So this has happened. So I think Biju has taken away some part of my topic. I was asked once to talk on surgical management, laparoscopic management of acute pancreatic necrosis. And the speaker before me, who was supposed to do it on open, he had almost covered all the ports and difficulties. But I'm fortunate that this topic could not be covered completely by my colleague, who was my colleague at SGPGI, because it's on bile duct injury, who should repair and who should not. more of a social reason. I will not start with a scientific point to begin my slide. My direct question: who cooks better food for you, whom you would like to have at home? Some may say my grandmom cooks it well, my mom cooks it well. At some places, yes, father, younger brother, younger sister, 5 years of age, very unlikely. So we can see a proportionate factor that the grandmother goes at the highest level because of the experience in the food. And now you have to take the other factor into it. You have to listen to it, that here you can say, I did not like the food, so I will not have. But if a surgery, you don't have a choice. Who should be asked to do a skin suturing? Since we are all surgeons over here, who should be asked to do a skin suturing at the end of the procedure? Can you ask your first MBBS student to do it? Second MBBS student? Final MBBS student? Internship? First year medicine resident? Any ophthalmology resident? A surgery new joinee? No. I think in the entire scenario, the surgery first year gets the choice, because it is again the hierarchy, that the seniority, the experience, which contributes. Whether it is cooking, whether it is skin suturing, we are still considering a seniority and experience which is having an important role. If once you have a first year resident, will you give a stapled skin suturing to him? Ethylon, normal suturing to him? Will you give it a mattress suturing to him? And then will you give a subcuticular? Now, as you get the variations into it, you will like some senior person to intrude into it. So before going on to who should repair a bile duct injury, who should be attempting a bile duct injury, who should do a lap chole? That is the first question. This is still unsolved till date. Who should be restricted to doing a lap chole? Once we have everybody doing a lap chole, definitely there's more likely injuries with the beginners. Is my slide moving? Sorry. So before doing a repair, we should know, why can an injury happen? These are all important for the repair as well. Is it patient related? Is it surgeon related? Is it instrumentation related? Is it the conditions related? Now, why can an injury happen? That will determine who can repair. Is it because of shortage of your time? You are having a long list. So if you're having a long list of 10 cases, if you have a bile duct injury, definitely you are running fast, and therefore in repairing also you will run fast, and that has created more problem. Were you worried when you were coming to surgery? Worry because of your senior, your boss, your fight with your wife? Is it because of lack of instrumentation? If you have a lack of instrumentation for a simple lap chole, definitely it will not suffice for your advanced procedure like hepatogastrostomy. Is it lack of assistants and the supportive staff in your OT? A routine procedure, if you don't have any senior people with you or a strong supportive system, definitely for an advanced procedure, you will not have again a supportive staff. Provided you have these all factors will work if you have adequate training, adequate exposure, and adequate experience of doing a bile duct injury repair. This is the group of people, even if with everything being adequate, they may have not adequate results. What basics we have to understand at this point in time, that we should always remember, the best time of repair is only once and the first time repair. It's not that there is not a second chance. It can't happen that if somebody has done a inadequate procedure, it cannot be repaired now, it cannot be improved now, it cannot be corrected. We have corrected it so many times, but definitely the first time when you get a chance, that is the best chance to repair for a bile duct injury. But with every coming chance, it decreases the outcomes and increases the problems. It increases the problems for the patient. He has to live a long time for a definitive surgery to cure him. For the family who has to suffer all this way, for the primary operating surgeon who has done a bile duct injury, for the surgeon who has done a first hepaticogystomy and then having a complication, and then now the final surgeon who is trying to attempt to repair it. It creates a problem for the person who has referred the patient to you for a laparoscopic cholecystectomy. It is worrying for the repairing team and the intervention radiologist who may be required. It is worrying because if it is a complex injuries, he has to show a wide anatomy in which he may have to require a large number of PTPDs. So always it is more difficult to repair in the present setting than the past setting. The past, which is the first setting, was the best chance of repair. Some of the facts, who should do a bile duct injury, which the facts which cannot be overlooked. Most of the injuries in our country happen with the specialist, general and laparoscopic surgery. Why does it do? It is not that it does not happen with an expert hand. They can happen with any expert, with anybody who's doing a lap chole. It can happen with anybody. But if you see the spectrum, if you see the numbers, if you see the volumes are with general and laparoscopic surgeon who are doing huge number of laparoscopic cholecystectomies, and then definitely a less number of trained surgeons over there can cause a large number of bile duct injuries. These injuries very often get referred from the peripheral hospitals, which are at the small cities where they lack the adequate facilities. At places with lack of availability of a very good post-operative care, I'll come to this in subsequent slides, why it is important that adequate availability of post-operative care cannot be overlooked. With non-availability of instrumentation to assist for a hepatobiliary surgeon. And at many centers, it even requires the sutures required of the PDS or 4050 PDS. I have faced all these things during my career, during last so many years, that these things are inadequately available. So these can't be overlooked, that who is doing a lap chole. The thought process, the surgeon who is doing a lap chole, we have to understand what is going on in his mind. I have shown a few slides earlier that what makes him do what can lead to a bile duct injury, whether it is stress, whether it is fight at home. You are coming to the hospital, your car gets a smaller injury or your accident, definitely that reflects on your surgery. And you think lap chole is a routine procedure, I can do it. No, definitely it affects your results. So thought process, what can a surgeon think at that point in time? First thing that comes always, I think it is not an injury. It is not a bile duct injury. It is something else which has happened. In case it is a bile duct injury, can I hide it? Can I cover it? If I can't hide it, if I can't cover it, if I think that it needs a surgery, can I repair it laparoscopically? I don't convert. If it requires conversion to open, but let's keep information to ourselves. Don't share it to anybody. I am doing an open surgery now. I tell that I have converted a lap chole to open cholecystectomy, but I don't want to share the fact that it has undergone a bile duct injury. I just want to share that it is just a conversion. I can repair. I think I have seen the residents usually say that I have seen a CBD exploration. So what is the difference between other CBD surgery and this one? Some surgeon may feel that, yes, I have read about bile duct injuries. I have read about how to do it, so I can try it. I think these are the thought process which comes first time to every surgeon who has a bile duct injury. The mindset of this operating surgeon is denial is the first thing. This can't happen to me. How can? I've done so many surgeries. How can this bile duct injury happen to me? It has never happened in past, but someday it has to come. A panic. What do I tell to the family? What will the patient's family, the 10 people standing outside, what will they say? What will I tell to my colleague? My colleague Abhinav is standing there, Biju is standing there, and then they come to know that Dr. Ajay has done a bile duct injury. How will I face them? Can I cover this? I don't have to inform anybody. That is the safest thing I feel. It's a wishful thinking that perhaps nothing will happen. Let me put a drain. Everything will settle down of itself. Now let's see if a surgeon has faced this problem. What is the data on this worldwide to say? Attempted repair by the same operating surgeon who has done a lap chole in UK. I want to put a reference, but I have not put. It is up to 50% times they will attempt a repair themselves. In US, it is still more, 60 to 75% time, they will try to attempt yourself. In Canada, it's again 65 to 75% times. In Italy, 95%. This is a documented data, which is says in Italy, 95% surgeons tend to repair themselves rather than referring. Oof. India, I don't know, it can go beyond 95. It will cross 125. I think more number of people are facing that they don't want to refer the patient. They tend to attempt to repair themselves. First repair by surgeon himself. Do we have something? This is all from Dr. Kapoor's book that he has mentioned on repair of bile duct injury, whom should be referred, that it is likely to fail because most of the surgeons who are doing a laparoscopic cholecystectomy are not trained, as what Dr. D.D. Yadav has said, in biliary injury repair, in bile duct surgeries. The success rate of a trained versus untrained surgeon. This is documented data. In a trained hands, it can still be, a success can be up to 95%, but in untrained, it is never beyond 20-25%. Most desperate attempts, the most desperate attempts usually made by a laparoscopic surgeon. He is doing a lap chole, he makes an attempt, then he will more likely to do more injuries. This is a fact which everybody universally will have to accept. He is more likely to make higher bile duct injuries, more vascular injuries, and inadvertent injuries to the other structures. I'll come to them in the coming slides now. Common wrongs. What can happen if a laparoscopic surgeon who is doing a lap chole attempts a hepatojejunostomy or a repair of the bile duct injury by himself? As in my last colleague, Dr. Biju and Dr. TD were discussing, I think they said they tend to dissect, and more dissection at the hilum, hence you tend to lose the length and convert a simple injury into a complex injury. Earlier, it was the right and left duct which were uniting. Now you attempt to go more beyond it and you get it separated in the subsequent stricture. More dissection means more vascular injury more likely. As Biju has very correctly said, don't try to identify or loop the bile duct at this point in time. You just need to repair the bile duct, and that is best done by the experts. All these things, whatever the first surgeon is trying to do, he thinks that he's trying to do it good, but unfortunately, this makes the surgery of the referring surgeon who has got the referral now more difficult. It is easier if he has done nothing. That is the best thing you can do to the patient. Best help to the patient and the surgeon who has to do a hepatojejunostomy by a laparoscopic surgeon is only two things that he can do. Rather, I would say three things that he can do. One thing is leave the anatomy as intact as possible. Second, make a controlled external fistula by putting a drain as close to hilum as possible. As Biju was saying, not into the left hypochondrium, not onto the spleen side where there was a collection. No, as close to the hilum as possible. Third thing, what Abhinav asked, the documentation, the record, and then Dr. Sadiq has very clearly emphasized, make a CD, make a record, and send it when you are referring. So make the life of the surgeon more easy rather than making it more complex. Give as much as data as possible. Why should it not be done at the same setting? Can I not do it? I can do it. I have done 100 cases in my life. I am a very senior surgeon. I have been seeing so many surgeries in my past. So, but it should not be done at the same setting. All the teaching has been like that. Why? I think we have to understand that for a lap chole, we just get a sonography done. But for a bile duct injury, we try to get a biliary and vascular anatomy both clear. That is very important. At the time of injury, the extent of injury might not be clear. You may do a cholangiogram, you may not have a facility of cholangiogram, you may not have been in a tune of doing a cholangiogram repeatedly. So the extent of injury is always underestimated. The vascular injury, you may assess a combined a common hepatic artery being injured, it may go unobserved. The complications, by the time when you are doing it, you are attempting to retract it, you might have done some complications which might not only in the CBD or the vascular structures, there might be an injury to the duodenum, other vascular structures, because your concentration is gone, you are under a lot of stress, you are under a lot of pressure, you are under the pressure of the patient family, you are under the pressure of your anesthetist. All these things contribute to your poor results. It is not just that you are not able to do it. An undilated ductal system, for any person who is a beginner in biliary surgery, it is always difficult to anastomose. Anatomical variations, we don't know what was the variation at this point in time. So it is very difficult to ascertain that how we can be repaired. For any major surgery, for lap chole, we don't have an extensive pre-anesthesia evaluation, a post-operative ICU in the same place, and extensive intra-operative systems like a central line or a complete monitoring of the vitals. So we may not have all these things in place, and we are trying to attempt a procedure which is much more requiring all these things. So is my OT tuned for all this? Is my hospital tuned for all this? Do I have a critical care team? Because most of the time lap chole are done in nursing home settings. So, but still we try to attempt a repair even in these settings. So for the team and the patient, evaluation is not done usually. A rule: unsuccessful attempts at repair decreases the chances of repair in the same proportion. This is a simple rule of finances, mathematics, simple number rule, that more the number of unsuccessful repair, more is the chance of poor result. If you are trying to do an unwanted resection, is also a part to it. If you are trying to go into the hilum, this is also contributing to it. It is not a simple interest. It is a compound interest that the patient has to pay. It is not just 1 + 1 = 2. The more number of repairs adds to compounding of the raised to the power of. Meaning to say, if the second attempt is there, it is not 1 + 1, 2. It is 2 raised to the power 2, that is 4 times more complex now. If it is going to the third time, it is 2 raised to the power of 2 raised to the power of 2. So 2 to the 4, 4 to the 8, it is 8 times more difficult. So it is not only difficult 8 times in the number of in the timing of the surgery, the difficulty for the surgery, but for the family as well as for the finances. What is more harmful? Let us assess this now. Psychologically, for the surgeon, is it more harmful referring the patient to a higher trained surgeon? Is it more harmful? Most of the surgeons think at this time that this referral is very, very difficult. How will I do it? How will I tell to the other person that I have done this big problem now? Or this is more harmful legally, that you are attempting a repair by an untrained surgeon and then leading to more complications and more harm to the patient. You have to decide which is more harmful. I think it is a psychological thought process that referring is more harmful. More harmful is a legal litigation which comes in case the patient is not getting adequate treatment in the repair in the coming days. You should take cost into consideration. Always repair by the primary surgeon is more expensive. I think sometimes some of the surgeons may think that what I am saying is not correct, but there is a data onto it. A primary laparoscopic surgeon doing a hepatogynostomy in an untrained center, subsequently referring and re-referring and requiring multiple interventions, normal cost comes to around, in dollars, it was 1.20 lakhs. Delayed repair by an experienced surgeon, that is only just 72,000. And primary repair, that is the least costly, by an biliary surgeon, that is 48,000. We have to understand that the third category may not be available always, which is least costly. But we think that the first category is the least costly, and therefore we attempt to do it, and that is a wrong way to do it. Now let's come to patient. How does he feel when a primary surgeon is repairing the procedure, is doing the injury? Lost the good and the happy days of life. These are usually young females who are undergoing a lap chole. So I think rightly said at one point in time when I was at SGPJ, Dr. Kapoor and Dr. Sadik used to say, these are the biliary cripples. These poor patients, immediate reference to an experience center in-house, it takes 15 days for recovery. No repair done and referred takes 78 days. Primary repair of injury and then referring takes average 222 days. This is a data from West. So if a surgeon has attempted a repair of injury and then attempted by a second person who is again untrained, then referring to a specialized center takes a longer duration for the recovery and hence more cost. If you have not done any repair but just referred, it may take a longer duration because you may take 60 days or 90 days for a waiting period and then doing a hepatogynostomy with a formation of bile duct stricture. Yes, of course, the center which is having a continuous liver transplant program or the surgeons who are trained with doing a bile duct repair with the undilated system will have the shortest duration because the patient may have to stay for a slightly longer time. So the best circumstances are in-house experienced team being called for help. If you have a team which can provide you help, yes, that is the best circumstance. You should call for a help if you don't have it in-house, if you're not in an institution, if you're in a hospital, you have a nearby hospital where you have a surgeon who can do it, call for a help nearby. Call for help if you cannot have anybody nearby, but he can come within time to your hospital. I think that is also acceptable within a defined period of time that he can come and help you out. Or if not, then refer the patient. This help does not mean that the person will come and do the procedure in a laparoscopic theater. Understand the gravity of this situation, which I was telling in the first few slides. It is not only one person surgeon who is going to do it. He needs to have a good assistance. A normal Thompson retractor is not available at most of the places. The normal needle holders to hold these fine sutures in a long thread, a fine thread, are not available. A loop to see the undilated bile duct is not available. And at some of the places, I have seen it as an evidence, even sutures are not available. I used to carry the sutures with myself. I used to keep them with me always because in case you are called for a bile duct injury, you will require it. At that time, it was Vicryl, now it is PDS. And stapler may not be available to do a hepatogynostomy because you need to make a rule loop. So anyway, that can be made by a hand-sewn anastomosis, but definitely if you have, it saves the time of the patient. Over the last 17 years, we have seen 63 patients with only 50% of them having a follow-up with me. Rest of the patients have been followed up only by telephonic communication by the people where I have gone and done a repair. That 2 of these patients had a poor repair. Let me tell, both of these patients, the surgeon was trying to do the repair himself. So let me again emphasize, don't attempt to do a repair yourself. It is better to call for a help and wait. Have a cold drink, have a coffee, have a tea at that time, and just wait for the doctor to come in or the trained person to come and help. Now, there is no definition about the trained surgeon. I had talked to many of my colleagues, and especially I've talked to some of the colleagues who are practicing in general surgery, not the GI surgeons or HVB surgeons. Whom do you think they should call as a trained person to do hepatogynostomy? So, some of the things which have come arbitrarily over this discussion was anyone who has assisted more than 100 hepatogynostomy. That is a basic requirement. This should include all variations. It should include a complex injury, post-PTBD hepatogynostomy, undilated ductal systems, long duct strictures, and routine strictures. And who has done at least 25 simple hepatogynostomies after this observation, which may include a hepatogynostomy for a PD, for a colorectal cyst, a dilated CBD, or a colorectal. And one who has done 10 bile duct repairs in undilated system. That is a primary requirement. Without that, you should not attempt a primary repair. This is only after point number 1 that seeing 125 other simple hepatogynostomies have been done. Please, a request to all general surgeons, don't take T-tube drainage as an experience in your bile duct injury repair. Most of the surgeons think that they have seen a T-tube drainage being done in their residency, or their colleagues or their seniors, and they have done a T-tube drainage. So that is not a part of bile duct injury repair. Then Whom should you refer? What is an expert center? He should have a diagnostic facility. Diagnostic facility means, I'll come to them one by one. Therapeutic facilities. And so diagnostic means a good radiology. Yes, MR is a good contributory factor, but nowadays we are seeing many of MRs which will not even show a good biliary anatomy. So that is not a good MR. It is a MR available, and there's a difference between a good MR available, which can show an undilated ductal system easily. A good CT scan, which has to be a triple phase CT scan, which should show a good biliary anatomy, good arterial anatomy, as well as a good venous drainage. Sometimes you may have to go for an extensive surgery, and maybe a volume assessment may be required. A good sonologist is always, most of the places it is available nowadays. Interventional radiologist is an intrinsic part of any center which is required to do a hepatic angiostomy in a bile duct injuries. A good ERC, a talented person who can do a ERC in such a system is always an asset. And a reconstructive surgeon who can do this surgery is definitely the bottom. Now, if accidentally something has happened and there's a family standing outside, you have to understand the psychology. What will hurt the family? We are thinking that we are getting hurt by our psychological factors as well as the legal aspects. These were two most important things which I felt. But what is hurting the family? If you don't take into consideration right now, you are going to do something wrong. What is hurting the family is you have not informed that complication has happened. You are trying to hide that. You are not putting the notes. And the complication is if the patient family comes to know later that there is a bile duct injury. You are hiding these truths, not taking part in their management. This is very important, which I want to emphasize. Once something has happened and you are referring to other center, I request put a good referral note, call to a surgeon. Maybe you will have to get an ambulance for this transfer. Maybe you will have to send some of your staff to that center. Please do it. That brings the confidence of the family in you. Though they may be hurting because something catastrophic has happened to them, which was not expected. So just participate in the family's problem at that point in time. Family being informed that this was a minor procedure. No, lap chole is never a minor procedure. Again, say, lap chole is a major procedure. Always take all surgeries as a major procedure and with a serious undertaking. Risk of conversion. It is not disclosed to the family. Always take a consent. Just tell them there is a less but a finite risk. There is no disclosure of the finances. The family thinks that how much will be the expenses when we go over there. Then quality of life. The female has to spend so many years of his life. The family suffering because of the bile duct injury, and definitely mortality is a very disheartening thing. So with that, I would like to thank for giving me this opportunity to speak on this. I would be happy if we can discuss on some of the points of
Ajay, Dr. Abhinav has asked a question in the chat. Maybe you can take that, and then Sadiq and TD can make some comments.
I'll just see if I can. Can somebody read it openly? Okay.
Yeah, I will read. He says that you quoted very high incidence of primary surgeon doing the repair or attempting the repair. Is it because of a medico-legal fear of litigation and insurance?
Yeah, I think yes, Abhinav, what you are saying is correct. Most of the people have. I told you two reasons why.
Yeah, because UK's NHS system where repair by primary surgeon just 50%, and USA where it is all paid system, and then you have insurance and litigations. So the incidence goes up to 75%, even higher in Italy.
Yes, Abhinav, what I have quoted is a data from UK and US, and they are definitely, in spite of being paid by the insurance, it is still the psychological fear in the mind. But if you see in India, it is not only the legal aspect. It is the worry that I can do it. Yeah, Dr. Kapoor wants to add something.
No. Please complete. Then I will.
So it is a worry in the mind of the surgeon. The biggest worry which I have realized over these years is, what will I tell to the family who's standing? I have gone for a repair, and I'm telling you, this is a ground reality experience. He called me from the back door. I entered the OT, did a hepatic angiostomy, and then he told that I'll not tell the family anything. You may leave from the back door again. I felt this is injustice. I told him, I think don't tell that I had come, but you at least tell them that there's a problem, because if suppose this goes into stricture, what will you tell them now? This is the emergency which we are tackling. So the worry is that the doctor doesn't want to inform the family. So therefore they try to attempt it themselves. Yes, Dr. Kapoor sir was.
Yeah. So Ajay said that data from India. I will just read a few sentences from a publication that we did about 3 years ago. My colleagues, Dr. Supriya Sharma and Anu at SGPGI, we did this survey. So we sent a questionnaire to about 700 surgeons, about 40% responded. So total 278 people responded. As many as 86%. 86% said that they have already had a bile duct injury during lap chole, and 78% said that they have had more than one bile duct injury. So it is not that once you have one injury, you don't have another. 78% had more than one. And then there were people who had a bile duct injury, first bile duct injury, even after 10 years of practice, and even after they had done 100 lap choles. So experience and expertise is not a protection against having a bile duct injury. 80% of the respondents said that they wanted or they decided to manage the injury themselves. So it's 80% in our country. And the mortality, total 728 injuries were reported in this survey, and 37 of these patients died then and there only in the injuring surgeon's hands. Some more must have died later. So 5% mortality minimum of bile duct injury in India. So these are data from a publication which we had 3 years ago.
I agree that this 80% is amongst the people who agree that I want to participate into this.
Yes.
I'm telling you, 98, 99% of the people who don't want to discuss this, who have had a bile duct injury. I'm recently, 2 years back, we had a person who used to refer us for a bile duct injury, and then we were conducting a survey, and we called him up twice, and then subsequently stopped referring us the patient. So it is as good as that the people stop participating into that discussion now.
One more query, Ajay, after that.
Yeah. Okay. Yeah, Abhinav, please carry on.
So Ajay, you told that I'm sure you have seen you going for emergency calls for bile duct injury when surgeons have called you. And as you said, you must have told the operating surgeon to sit quiet and do nothing and have tea. So how many of them were sipping tea when you went there, or they were still trying to operate despite your advice not to go ahead?
Yeah, two things which I have seen is when they are doing a laparoscopic cholecystectomy, they have found the bile duct injury during laparoscopy, while the procedure is being done, and they inform me while the procedure is being done. I think they were still doing laparoscopic something or the other. I told them not to open it up. So when they were following it, they were still doing something laparoscopically. The biggest catastrophic change was those who have opened it up and then informed me. If they've opened the abdomen and informed me, by that time they will try to either puncture the bile duct or go into the hilum or something, and they will do more vascular injuries. So I think two patients of ours had again a stricture and then subsequently had a bad prognosis. But they were one of them had a complete hepatic artery being ligated during this attempt by the surgeon.
So they don't stop till the help is reaching there.
Yeah, that is a common scenario everywhere. I think Dr. Sadiq can add on to it because he gets a lot of referrals nowadays.
So thank you, Ajay, for that interesting presentation and the issues which you raised around the surgeon and the patient. So, I mean, the topic was who should and who should not. So the answer, I think, is very clear that A, inexperienced surgeon or surgeons who don't routinely do a bile duct or hepaticojejunostomy should not repair. The second thing is primary surgeon should not repair. And I'll elaborate a little bit more on that. The point which we have to understand is you've raised a lot of issues about hiding and things like that. Bile duct injury is a double hit. It hits the surgeon and hits the patient. I mean, let's not pretend that the surgeon who is or had a bile duct injury is not affected by it. And a lot of it is a defense mechanism which they employ, though wrongly, in terms of trying to hide and cover it up. So I think the message which we should say is, if you encounter a bile duct injury, in your own interest, in a protection for litigation, the best thing is to assess, communicate with the relatives, and refer. So these three things, the primary surgeon who is not capable or does not have the wherewithal and the setup to do the repair should remember this. So communication is important, referral is important, and documentation of injury is important. And it is it's actually a protective thing, that injury has occurred, which may occur due to many reasons, but the right step has been taken considering the experience available at that point of time. The second thing is, if the injury occurs in a setup which has all the facilities, should the primary surgeon repair? And I think there also, I feel that it may not be appropriate. And this would be a scenario where you will have enough help and experienced help available. And this is simply because an injury which happens, there is a lack of confidence, there is anxiety, this is fear of the repercussions of that. And therefore, it is always good to get another colleague who's equal experience, if not more, to come and do the repair at that point of time. The second point which I want to emphasize, and you said that, is it a right time to repair at the first time? And I think there are caveats attached to it. There are several caveats attached to it. And we have to fulfill each and every caveat if you want to do an early repair. So the important thing is, of course, an experienced surgeon, a good setup with all the things that you said about retractors, instrumentation, sutures, etc. available. There should be no sepsis. That means it is very early referral. If it is on the table and you are there, you would be able to get the information by assessment whether there is any vascular injury or not, and the level of injury. And then, as you said, you went and repaired, so you had made an assessment, and it is possible to do that. If the patient is referred early, you have time to do an evaluation. So I think before you take up this patient, you should do an MR and a CT angio so that you can get a complete assessment of the extent of injury and the vascular injury if available. If the referral is beyond a certain point, and that point is undefined, whether it is 48 hours, 72 hours or so, for me, the cutoff would be about 48 to 72 hours when there is bile in the peritoneal cavity, which has not been drained and the patient has been referred. Here, if I'm not contemplating a primary repair and I may just want to do a laparoscopy, do a lavage and put a good drain, I will not do much assessment at this point of time, except for maybe doing a CT to assess collections so that I can target them appropriately when I'm doing it. But I'm not going with a mindset of repair. But if I'm going with a mindset of repair, then I would do minimum those evaluations. So I think who should not repair is very clear. Who should repair? Maybe there may be some question marks at some point of time, but in my mind, I'm clear that the operating surgeon in any setup should not repair. He may be part of the team if they're all experienced HPB surgeons, but should not be the primary person repairing.
Points well taken, sir. I think yes, sir, Dr. Kapoor.
Yeah. So again, at the cost of repetition, three important prerequisites for any repair, and especially intraoperative or immediate repair or early post-operative repair, are, as has been again and again and again emphasized, a biliary surgeon, good and complete delineation of the biliary anatomy, because unless we know what the injury is, how can we repair it? And which requires, if it is intraoperative repair, it requires a very good quality cholangiogram, which we know that even in good and big institutions is a logistical problem. It is very difficult to get a good intraoperative cholangiogram. And third is, even those who believe in immediate or early repair, they say that if there is an associated vascular injury, they would not do it. So vascular evaluation also is very important. Now, intraoperative vascular evaluation means that you need an intraoperative Doppler. And as Dr. Sadiq pointed out, if you're going for an early or a late early repair after referral to a biliary center, then you need to have either a CT or an MR angiogram. And Anu is trying to connect, but Anu will give us the data that when we prospectively looked at the presence or absence of a vascular injury in a bile duct injury, a large number, I don't remember the exact number, but it was, I think, to the tune of 30, 40 or 50% of these patients had an associated vascular injury also, which happens very frequently in lap injury, because when you are mistaking the common bile duct for cystic duct, you are very likely to mistake the right hepatic artery for the cystic artery, and that would have been clipped and divided by this time. So these are the prerequisites. One more point. Most studies, of course, these studies are from the West. There is no official publication of medical legal data from India. The factors which are responsible for a case being filed and a case being successfully decided against the surgeon are obviously death of the patient as a result of bile duct injury. Second, a failure of repair. And third, and very important, repair being done in the injuring hospital by the injuring surgeon. That has emerged out as a very strong risk factor for a case being filed and a case being decided against the surgeon. I point out to the colleagues who are from India that there are CELSI guidelines for safe cholecystectomy and intraoperative or early management of bile duct injury. And they say that if you are not a biliary surgeon, you should not attempt a repair. You should refer the patient to a biliary center for endoscopic, radiological, or surgical early management. So that is a protection. As Dr. Sadiq said, this is a shield. If you do follow these guidelines in the court of law, even if a case is filed against you, you can say that I followed what the CELSI is saying, rather than do something which will be undefensible. So three more experts have joined on the panel. Dr. Sadaf is there. She's the chief of GI surgery at SKIMS in Srinagar. Dr. Vishal Gupta has joined on this. He, as I said earlier, is the chief of GI surgery at AIIMS Bhopal. And Dr. Shahidur Rahman, who is a very senior surgeon from Bangladesh, he was trying to join on the delegates link but could not join, so I invited him to join on the Zoom link. Also, the third talk was to be by Dr. Bhojwani, but he just called his colleagues called that he is still busy doing a procedure and it's a pouch, so he can't kind of scrub out and leave it to somebody else. So what Sadiq and TD, I will request that we can convert his topic. What should a general surgeon do? Of course, some of it has been covered, but what exactly the surgeon should do if the injury is recognized during cholecystectomy, and before that, if the other experts would like to make any comment, and then we can maybe take up that topic. Sadaf, you want?
Yeah, I just wanted to add
Ajay, no, since let Ajay respond first. He was the speaker.
Sorry, because so just I wanted to emphasize on the fact that in India, the worry is different. There's a different ground of worry. Most of these centers are at a rural area or a semi-urban areas. Worry is that the court case will be settled or will decide after 15 years. But the threatening of the family is immediately outside. That is the worry. So that's what the deciding factor in India is. So I think that we have to teach them how to tackle that and how they can help themselves from that. Yeah, please, now Dr. Sadaf.
I think the solution to that, Ajay, is what we have been thinking. I will mention it, but we haven't started it. A kind of a helpline, biliary helpline, a video consultation where the surgeon can talk to us, giving the showing us the live video of what is happening during the cholecystectomy, and then we advising him what to do, what not to do. We are still not sure what will be the medical legal implications of this, how much will be our legal responsibility. So that is one. Second, as you said, that if possible, in the same hospital, in the same city, or even a nearby city, if somebody can come in a reasonable period of time, intraoperatively, and then advise what is to be done. And last, of course, is a referral. Yes,
I think
Sadaf,
that
please.
is one of the best supports, that somebody can come and do the surgery in their setup. Because I remember going to far away places where the patient was extubated, and we have retaken up for surgery after a few hours, because patient could not be kept at that center under anesthesia, and then did a hepatic cholecystectomy and then came out. The family was at least convinced that they are not getting bothered, and the biggest worry for that surgeon was that he was operating upon a patient who was the inspector of his thana nearby, and he got injured. So you can understand how much worry is in his mind. So the only way we can help, I personally feel we can help, is we have all the instrumentation, go to that place and help. I know that the facilities will be less. I agree to it.
Yeah,
Sadaf.
I wanted to make a few comments that I think Dr. Abhinav did not touch the aspect of investigating the injury, because we are taking it into pieces in different section. And he is very generous in reaching out to far off areas also. But going and reintubating a patient, I just wanted to talk to him before also, because he mentioned at many instances where we left the opportunity from going from Srinagar to say Sopur or a far off district when it's not within your city, is practically not possible, especially in context to the patient waiting and the time duration of your travel and all is to be considered. That's a very important point. So in those scenarios, I personally have a view that if the cholecystectomy cannot be done within the area, then it's very difficult, practically not possible. So there are so many practicalities to things. And gallbladder surgery, as he has rightly put up, should be taken up as a very serious kind of surgery amongst. Of course, you take all surgeries very seriously. But if you have good communication skills for the smallest procedure to the largest procedure, on first encounter, the patient's family should have confidence in you, so that those all anxiety factors you discussed should not put you down in, spoiling the patient further. This is what is very important. From the day one, when you're planning a cholecystectomy, you just need 5 to 10 minutes to have a good rapport and communication with the patient with all those points which you had put forward. And this should be practiced by all general surgeons or those who are laparoscopic cholecystectomy surgeons. That's all. And it has been a very good presentation. All three of them had been perfect to the topic allotted to them.
TD, maybe I can start with you. Rajesh, sorry, you want to say something?
No, I just want to say that to the Ajay's comment about going to the center. If the center is very small, and if you are going with the only you are going, we might take some needle holder and suture material. But what about the other paraphernalia which is required for a good hepaticogestomy in a undilated system? I think it's a very, very difficult in our country. If you are talking about outreach program published by Birmingham Group, their district hospitals are very equipped. So I think I would be very much worried for that. Second important point is what you said, that 95% we also get lots of referral of bile duct injury, and about 5 to 10% of our people have done, they have been done a hepaticogestomy as such, not other form of management of bile duct injury. So hepaticogestomy taking at the same center in our referral is very less. What point is very important, what you emphasize for everybody, maybe sir was talking about the Bhojwani's talk, we can take it in that context, that it's very important when a surgeon calls to have a repo, like in Punjab, lots of surgeons have our numbers, and when they are referring a patient, they talk to us. That gives a patient also confidence that the surgeon has talked to the person concerned, and the moment a person lands up in PGI in emergency, our resident knows that we take our resident, that patient is coming, this is the name, and if patient comes, you go and take care, don't discuss anything and do whatever this thing. So patient is coming and he gets respect in PGI in emergency where nobody is so much crowd is there. Suddenly patient gets respect, and the problem of litigation as well as management also is better, and the litigation problem also goes lesser. Third important very point is whatever logistic you talked about the availability. These are our responsibility. If you don't have all these facility, I think we should not be repairing, as sir said. Only surgeon, as such. Suppose I go and tomorrow in a small hospital in Allahabad. So should I be doing hepaticoagulopathy? It's more important to have a multidisciplinary approach. Then only this biliary enteric anastomosis should be attempted. Sometimes it is so difficult that we think, we pray Almighty that why we are only here, why not somebody else should have been at my place, not the me. So these are, I think, very important issues. And as you emphasized, surgeon trained, magnification, and having good suture material and instrumentation, good this thing retractor system, maybe not one company, there are multiple table fixed retractors. All these things are there. Then only we should start adapting, as in this scenario where we are talking about intraoperative, where bile duct is totally undilated. So it may be 4 to 5 millimeter. So we have to go up, and then we have to go to the base of the ligament, and there the dilatation is much lesser. So these are the important points. Then we can then we have, these are the important points I wanted to discuss, apart from what
So let's also invite Vishal is there if he wants to make some. Biju is there.
Vishal wants to say something. Vishal, please come in.
Sir,
good evening to all.
First
Vishal, just a minute. Ajay wants to respond.
TD sir has raised. I think I'm fortunate that Abhinav is here. We were in the same hospital at that point in time when we got a first referral, a second referral within a gap of 10 days. And then we decided that we'll make a kit which we'll take out immediately. So we used to take the entire staff with us in the same car, the instrumentation in car, because it is, and even the sutures, because we knew that there will be nothing. So it's, and the surgeon is under a lot of pressure, the family is standing outside, and we are just trying to help it. Yes, I agree. Sometimes it may be more catastrophic. It may not always be a help, but getting the patient from there to our center, once you realize it can't be done over there, is better and brings confidence to the family as well. So I think, yes, we need to have all instrumentation, everything in place. Dr. Vishal, please.
Vishal wants to say something.
No, I think for the primary repair, sir, even if we are called to the center by the primary surgeon, we cannot always commit that once we attend the patient, definitive repair will be done at the same time. I think personally, I would defer the case if I feel that this is a complex injury. There may be underlying some vascular injury, because at that center we don't know facility in terms of like CM availability is there or not. So if it is a simple, straightforward injury, then we can actually think of doing the primary repair as an expert surgeon. But in case of complex injury, it is better to assess and then put a drain, close it. We can counsel the attendant that this is a problem that we have to assess it at our center with CT scan, MRI, and then we have to decide whether we should go for the early repair or the delayed repair. Second point, sir, that Dr. Biju said, the primary surgeon should defer and refer. The general dictum is that you refer early and repair late. So referring early is the responsibility of the primary surgeon. So they have to think that once they have decided to refer the patient to a particular center, they should not wait. They should refer as early as possible. And third point, I think there is a concern with the primary surgeon and the attendants is the psychology that if they do the repair by themselves, that would be the one-time treatment for a complication of the cholecystectomy, because there is a concern of morbidity that lies when patient is referred to some other center. There are uncertainty when this patient will be attended, how long that it will take for the final repair to be done by the experts and expert surgeon. There may be concern of morbidity related to the bile leak, especially the biliary fistula, when we actually plan for the delayed repair. So sometimes that happens, that injury happens, and the primary surgeons thinks that if he repairs at the same time, that kind of morbidity will not be there, and it will be just one-time treatment of the complication that has happened. So that is just the psychology that goes around in the mind of the surgeon as well as the patient. Because once we explain to the patient that this complication has happened, the another point comes with the attendants that can it be repaired at the same time, because they also want to avoid all the problems with the referral waiting period for 4 weeks, 6 weeks, or maybe longer. So there are certain issues in the mind of patient, in the mind of primary surgeons. So these are the points I just want to make.
Yeah, there is a question.
I totally agree with what you are saying, what Sadaf was saying, and the point what TD was saying, that just being able to reach a place doesn't mean that you're going to repair that injury. And if you can, the whole team can go there, I'm sure it is equally easy to shift the patient to this. So it's only a question of communication between the primary surgeon and the team, patients and the relatives. If you are able to convince them, you're able to put across the point that why it is favorable for them to be shifted there, I think it would be much better decision making. Because if you go to some place, you are also under pressure that you have to perform and do the repair. Because having reached there, if you say, oh, I can't repair, then, it's the same kind of pressure which the primary surgeon is facing. The second point is we often say that unfamiliar places, if we want to do a complicated surgery, it's not the best place to do it. And here it is, as we have been talking, it may be a high injury, it may be a small duct, you need all proper light and things like that. And then you reach there and it's not there, it's not worth it. So if you want to repair it, I think you should convince them to, in our setup, as TD mentioned, that in Western setup, they may still have much better facilities, but in our setup, better to get at our center if you are contemplating a primary repair in this scenarios.
There is a question from Dr. Karthik. I will take it. Karthik wants to know, is routine upper GI endoscopy to be done pre-operatively before all lap chole, even for simple symptomatic gallstone disease? I think Karthik is referring to the problem of portal hypertension, which can create a problem and make a cholecystectomy difficult. But obviously, it is not recommended in all patients who are going for cholecystectomy. It is only when you have a suspicion of chronic liver disease based on history, based on imaging, based on liver function tests, based on your clinical examination, that yes, you may like to do. But otherwise, no, it is not. Abhinav has asked a very interesting question. I will read it out because the audience delegates cannot see. He says that once AI comes in and robotic cholecystectomy comes in, which is supported by AI, artificial intelligence, because it can raise an alarm if the surgeon is losing the plane or is mistaking a vessel or for a duct or whatever. Will it decrease the risk of bile duct injury in cholecystectomy? Is there any evidence? Is there any data? Biju, Sadik?
So there are programs now on software available which you can superimpose on the image that you are seeing, and it at least tells at a point that you are in the wrong place of dissection. But it's still evolving. It is not foolproof at this point of time. But these are publications in Annals of Surgery which has come, and there are commercially available softwares which you can sort of introduce in your system, and at every point of time you can superimpose that and get an assessment that whether you're in the right place of dissection. And I think there's a lot of work which is going on in that, and hopefully if it is affordable and if it is usable by everyone in peripheral centers again, it should, or at least it would sound an alarm that you are in the wrong place. So that's possible.
Sadik, I would disagree, because unless you have a cholangiogram, how would even AI tell you whether it is cystic duct or common bile duct? You have to have a pre-operative cholangiogram which can be superimposed on the operative.
No. What it does is, I mean, the way principle this works on is, it is basically large data collection. So what it does is it processes a whole lot of videos of cholecystectomies which are going on, which have gone uneventful. And then it sort of establishes a pattern that this kind of anatomy and this area of dissection is safe. It doesn't say what is the bile duct, what is the cystic duct. It says that the area of dissection is unsafe, or this place where you are dissecting is inappropriate. the surgeon will still have to choose whether in that particular situation it is there or not. So it is just large data processing. And when you process large data, you get various types of cholecystectomies, which you put in that. And then there is a lot of work, each one saying in each video that which is the correct thing and which is the abnormal place to dissect. So it comes out after a lot of pre-work in that. And that's why it is not foolproof as yet, because there is such a wide variety of anatomical variations and situations which we encounter.
So for the last topic which Dr. Bhojwani was to cover, I will pose questions to primarily Sadiq and TD, and maybe other panelists or other experts can also respond that what should a surgeon do? So I am a general laparoscopic non-biliary surgeon. I'm doing a lap chole. I'm doing dissection in the Calott's triangle and I see a drop of bile. Sadiq.
No, again, as we discussed, when I'm dissecting in that area and I see a little bit of bile, I am worried. So that's the first thing. So as you said, it's yellow sign, you stop. Then you assess the bile. You look at, as you mentioned, the characteristics, golden yellow, thin, watery, free-flowing bile from the central area and not from the peripheral area of the thing. And as I said, it is identifiable source of leak, unidentifiable. And identifiable, what I mean is, usually you can make out that it's the gallbladder which has been punctured in that. And you know that it's nothing to panic about. But if it is unidentifiable, central, golden yellow, wait, stop, and then get somebody to have a perspective on that. If
nobody is available, I am all alone.
Nobody is available, and if the suspicion is high, which you should be having at that point, I think I would suggest for them to stop there, put a drain, and come out at that point of time. Less harm done at that point than doing any more dissection or
no further dissection,
any more evaluation of that. And refer this patient.
Very important. So if it is in the Calott's triangle, if it is central, if it looks like CBD bile, you cannot make out what is happening. No help is available, Dr. Sadiq says, and I fully agree. Don't do any further dissection. Leave a drain and come out. TD, same situation, but it's a thin-built patient. There is no fat in the hepatoduodenal ligament. I can see that there is a hole in the CBD. Cystic duct is seen, gallbladder is seen, cystic artery is seen. I can see that it is a small hole, maybe caused by the tip of the hook or whatever. And I'm very sure that it is the CBD. What should I do? I am a general laparoscopic surgeon in a small nursing home.
Sorry, I think if it is, we are sure that it is common bile duct and we can see the anatomy that it is looking like bluish and whole length we can see. Then probably we can complete cholecystectomy and put a drain. Nothing to that hole. Put a drain and then next day we can start. We pharmaco. We say this pharmaco sphincterotomy, and then we can start Buscopan and see, and then we can also think about what is the drain output. Based on that, we can talk to our medical gastroenterology colleague and go for medical sphincterotomy, gastroenterologist colleague, and go for endoscopic sphincterotomy if required. Otherwise, if it is very low output and if it is going down, then it will heal on its own, most probably without any problem.
What about suturing that hole?
Suturing is, sir, as we are discussing repeatedly, suturing is create more problem, and even the size of the needle can puncture. Bile is a detergent. So more you puncture, more bigger hole you make. So it's just if a small hole can be left alone, can be sphincterotomy can be done. Obviously, one drain has to be put in the subhepatic area. So
you mentioned about pharmacological papillotomy, Buscopan. Can you elaborate on that? When do you start?
Yes. We start sometimes some difficulty is there. We start in the evening only by IV, and the next day we can go switch over to oral and go for a week. So That is we follow sometimes when we are having a patient where we feel that some clip is not very good or something like that, then we immediately start this type of medical sphincterotomy. Though there is no much literature on that, but these are the things which can be done. Obviously, next day, how much is the bile output? That is very important in the drain. And what is the condition of the abdomen? All those things will decide further management.
Only thing I will add before I hand over to Sadiq is that in any of these situations, the same time, the same day, you have to inform your medical gastroenterologist, the endoscopist, that he or she should be ready for intervention, maybe tomorrow, maybe day after, depending on the clinical course of the patient, and because that would definitely be a help. Sadiq, you wanted to say something?
I mean, I think it is important what scenario we are looking at. And if you're talking of a general surgeon in a small place, so I think all what TDS suggested I would do, but along with that, I will refer this patient immediately, because no point keeping that patient and trying to observe how much bile is coming and all. And I'm of the opinion that, again, bile is not good for the peritoneal cavity, even if it is coming out in a drain. So if you refer, you may be able to do an early ERC and put a stent so that bile leak is minimized. But in a setup where you don't have, as you said, if you have a medical gastroenterologist, yes, inform and you can take a decision. If you don't have that facility, then I think refer, even in the same city, immediately to a place where they can evaluate and take decisions based on what's happening.
TD,
Can I say one thing?
Yeah, Vishal, please.
Sir, I think it will also depend at what stage of the procedure we can see the bile. Suppose cystic artery has already been divided, and then we notice some bile in the hilar area or in the Calot's triangle. Then should we leave the gallbladder in situ?
Yeah, you asked that earlier. Biju addressed it, and Sadiq also addressed.
Sorry, I was on the YouTube earlier.
Yeah. So what Biju felt, that if you haven't separated the gallbladder from the bed to a significant extent, you will have some blood supply from there. And he was of the opinion that you need not do any further dissection, because obviously if it has happened at that stage, which means that you haven't done any dissection in the bed. That was what Biju's opinion.
But can we go ahead with a subtotal cholecystectomy? Because we are not dissecting in the Calot's triangle. Even if we see some bile in the Calot's triangle, so if we take out the part of the gallbladder like we do in the subtotal cholecystectomy, so that can avoid the risk of ischemia.
Yeah, I personally would agree with Biju that if not much part of the gallbladder has been separated from the liver, I would probably be advising the surgeon to just stop, do nothing. Because see, that means that there is something wrong. And the more you try to do dissection or anything, probably more injury is likely to occur. That is what my personal. So the second scenario, yeah, Sadiq.
No, go ahead. Let's do
second scenario, TD. We have done the Calot's triangle, cystic artery, cystic duct. We were clear. A critical view of safety demonstrated. There is no problem. Now we are dissecting in the gallbladder bed. I'm using cautery, and I see a drop of bile there.
So again, sir, same thing. Is this drop of bile coming from the bed, from the liver area? Then obviously it would be as golden as it is for the common bile duct, or it is because of the puncture of the gallbladder. So
it is not gallbladder. Gallbladder is intact. I don't see any hole in it is in the GB bed coming from the liver.
So and we are not seeing any tubular stricture. So there would be two scenarios. So while dissecting, are we able to see any tubular stricture? Then we can think of about this bile duct, sectoral duct injury, duct of Luska, whatever we call it. And if you are not seeing any tubular structure and the duct is so small, then again, I think putting a drain and going by the same thing what we discussed, that we can refer and put a drain and this thing. Otherwise, if you are able to see the tubular structure, then probably intraoperative cholangiogram might be required here.
Cholangiogram not available. I am working in a periphery nursing home.
Then putting a drain and referring the patient again to the.
And what about clipping it?
Clipping, sir, as I said, tubular stricture, if you are seeing, you can clip it, but that size is very important. If it is very small, less than 3 mm, then probably it is draining very small segment. But if it is more bigger and you can see a tubular structure, then probably referring would be better, because clipping, the only thing is that whether it is connecting to the main system or not. If it is not connecting to the main system, then it might have type B injury, which might not have any consequence in the future, and which might produce sepsis in terms of that segment not getting drained and then stasis and going having some sort of a small abscess formation. Otherwise, it might not have any consequence if it is very small. So putting a drain and I think sending would be much better, and then doing a cholangiogram later on in a higher center, and then deciding further planning.
So I have a slightly different take.
Yes,
Can I, Dr. Kapoor? Dr. Kapoor is, so we have bypassed him. We can do what we want.
Yes.
So, see, I think, TD, you are worried about aberrant duct, right? And again, that would be a little more central than peripheral in that.
Yes.
In this situation, which Dr. Kapoor was probably hinting to, is you are dissecting the GB of the liver bed, and then you encounter there's two situations: cholecystohepatic duct or duct of Lushka. Both of these, I think Dr. Kapoor is calling. Let me just take that. Yes, sir, you got disconnected. We कर. Okay. I think he's got disconnected, so he'll probably join, or we'll end at 9 o'clock. So if it's a cholecystohepatic duct or duct of Lishka, I think we are okay to clip or suture whatever you are comfortable with and take care of it. Of course, put a drain and then follow it up. If it is more central in that area, then there is a remote possibility of an anomaly wherein a right posterior duct opens into the gallbladder or into the cystic duct. We have seen that very rare over all these years, one or two cases like that. If that scenario is, then what Dr. TD was mentioning are the considerations that if it is very small, you may still clip it. Clipping a small duct is much easier because it doesn't result in continuing bile leak, and if it is a small segment, it will atrophy. But just by the size, we cannot say what area it is draining. So in such situations, my philosophy is exactly like what TD described, that if I suspect that it's an aberrant duct which has been injured, then we would put a drain and assess later that what kind of injury it is, and subsequently go on for repair. And this is not the best duct to repair early also, because these are much smaller and more difficult to repair. So I think we are coming to 9 o'clock. I'll say that if Dr. Shahidar is there, if he wants to make any comment, he's welcome to. Dr. Pratik is there if they want to make any comment before we close the session. Dr. Kapoor is particular about closing on time. Dr. Shahidar?
Yes, sir.
Would you like to
can you
make
listen
any
me?
comment? Yes.
My one question to the all learned speakers. Is there any way to assess perioperatively that these patients have biliary anomalies or have biliary problems like inflammatory adhesions around the calostangles? Is there any way to understand? Is there any way to assess before operation of the cases?
Biju, is
so that we can avoid biliary.
Biju, are you there?
So, yes, sir.
Please answer.
So, we cannot, point number one, we cannot improve the safety of cholecystectomy by pre-identifying the anomalies and by teaching somebody about the anomalies in an extensive way. The reason is, anomalies are there either in the arterial or ductal side, at least in 50%. Okay. So, let us say in arterial side, 500 cases we have evaluated the CT. The classical anatomy, we have seen so-called classical anatomy only in 27%. So what are we trying to teach as the anomaly? So this is a difficult area. So cholecystectomy should be done based upon principles and safety rather than trying to educate somebody about the HPB, bile duct or artery anomaly. This is what my message. So apart from basic simple anomalies, complex anomalies need not be learned, and that will not improve the results of cholecystectomy or safety.
Dr. Biju, I think what he wants to know, pre-operative, can we predict? So I think if Meiji syndrome, Dr. Saidur, and if there is a history of endoscopic stenting and removal of common bile duct stone, or stone as such, presence of stone as such in the common bile duct, and then small contracted thick wall gallbladder on ultrasound, and then there is a palpable gallbladder lump, which makes the size of the cystic duct and the length of the cystic duct very small. So these are the some pointers towards the and a history of acute severe cholecystitis and acute cholangitis also. These are the some important points which predict that this gallbladder might be difficult in terms of doing cholecystectomy.
Thank you. So Dr. Kapoor is here, and he'll probably
need to close because we start on time.
So, may I add another questions?
No, please. Tomorrow. We need to close at 9 p.m. So,
yes, thank you.
Sorry, Dr. Shahidur. Tomorrow, please join and we can have a.
Okay, thank you, sir.
Yeah, thank you. So, I would like to thank Sadiq and TD for moderating, and Biju and Ajay. Rajesh Bhojwani could not join. He was busy, but I think Ajay and Biju and Sadiq and TD covered most of the points which Rajesh was to cover. Thanks to Abhinav for joining today, although his session is tomorrow. Thank you very much, Abhinav. Thanks to Sadaf. Thanks to Vishal, Professor Shahidur Rahman. So we will continue this masterclass tomorrow at 7. Yeah. Good night, everyone.
Yes, I'd like to join tomorrow.
Thank you very much. We had about 60 plus delegates watching live, and the views of the uploaded videos is much more than that. So I think our effort is not going waste. People are watching these sessions, and I am sure they are liking it. Thank you.
Thank you, Dr. Kapoor.